Thank you very much. Good morning to all of you. I'm going to talk about anterior vitrectomy in middle segment surgery. When we talk about middle segment surgery, we have in mind either surgical approach for cases presenting with pathology in the middle segment of the eye, or the surgical treatment of anterior segment pathology, but challenging cases which need to be approached via pars-plana, or both of them. There is currently a debate, let's say, or discussions about what type of surgeon should resolve these problems. Should it be the VR surgeon or the anterior segment surgeon? Anyway, if we are talking about an anterior segment surgeon, he or she first needs to perform a correct anterior vitrectomy, and second, for him or she is advisable to convert the middle segment surgery in an anterior segment surgery where the surgeon feels more comfortable. There are a few principles of anterior vitrectomy: anterior chamber approach versus pars-plana, dry vitrectomy versus infusion and BSS, to keep a closed system, to create best visualization conditions, use triamcinolone in larger devices for the pupil if necessary, and to use the machine capabilities in the both systems, IA cut or vitrectomy mode. Since we are talking about middle segment surgery, I would highlight the pars-plana approach, vitrectomy under BSS, infusion in pars-plana, and of course we are working through the sclerostomies. Let's see one of the cases. When do you face middle segment surgery most often? It's the subluxated lens. Once this patient had a good surgery with an IOL well implanted in the bag, but due to PEX or other things, the bag is completely dislocated. When he sits at the slit lamp in front of you, he's standing and you cannot very well appreciate the depth of the fallen IOL and the bag. That's why UBM is helpful in appreciating the distance between the complex and the iris, so can help you in deciding for one of approach or the other, pars-plana or anterior approach. In this case, I did an anterior approach with infusion in the pars-plana. Vitrectomy is done via paracentesis, although it can be done through another sclerostomy and trocar for 25 trocar for sclerostomy, and this is my preferred technique for solving the aphakia. So we convert the middle pathology into an anterior pathology, as you just saw. Another case is this one, in which, of course, the IOL is much more decentered, but you can see a suture there. The history is of vitrectomy for retinal detachment, and the IOL has been sutured by by another surgeon. In this case, also an anterior segment surgeon can approach this case because of two reasons. It's already a complete PPV, so it's not necessary anymore another one. And IOL to be removed is hanging on the remaining suture, so there is almost no risk to fall on the retina. So you don't really need a VR surgeon in this case. You can do it yourself. Let's see the third case. This is a case with much more decentrated IOL, as you can see in the pre-op picture, and UBM also shows you no IOL in the field that UBM can achieve. And of course we need to explant it, a minimal anterior vitrectomy, but in this case I decided to work, let's say, as a VR surgeon, because in the last 5 years I do VR surgeries. I explanted always by cutting the IOL in 2 or 3 pieces. My pupil became small. I enlarged it with hooks so I can have a better visual field, let's say, a better field of vision. And I explored the peripheral retina, and luckily I found a break which had an appearance more or less atrophic, but just to be sure I put some laser and took advantage of the presence of correct anterior capsulotomy, and I put a 3 pieces IOL in the sulcus. What about the cases unexpected, with unexpected complications? So I'm an anterior surgeon, I want to do this cataract surgery. It is a femto laser, and this is what happened when I just touched the nucleus. I checked, was it a run out of the capsular rhexis, which sometimes happens when you have femtosecond, unfortunately, but no, the capsular rhexis was there. So I didn't have my colleague, my VR surgeon, that was 8-9 years ago. I just wanted to aspirate and to change my former anterior segment surgery became middle segment surgery, and then I wanted to bring it back to an anterior segment surgery. I wanted to elevate the nucleus, but please don't elevate it mechanically and that's all, or only by aspiration. First, as you saw in my video, you need to make some vitrectomy in front of the lens and around the lens, so you don't want to, because you don't want to pull the vitreous. And I managed to bring it in the anterior chamber, and I just continued as an intracap. Old-fashioned intracap or extracap technique is can be very helpful in cases like this. I'm not afraid of post-op astigmatism, but I would have been more afraid of damaging the cornea if I would have continued with phacoemulsification in the anterior chamber. Luckily, in 9 years, nothing happens with the retina in this case, but maybe nowadays I would have to check the retina as well, which was not the case. And the last case, again, a complicated anterior segment surgery. This was a bullous chiropathy supposed to have a DSEC or DMEC. I started the Desamet stripping, and at a certain point I saw that an air bubble went back behind the iris, came in front of the iris, and I said, okay, what happened? What's happening here? Because I knew the patient had the posterior chamber IOLs from the medical records. I decided to see what's going on, and I converted the DSEC or DMEC in PK surgery. I checked for the IOL. It was difficult to see. The pupil was small, and indeed here it was a PC IOL hanging on one suture. Of course, the eye is bleeding now because of the hypotony. It's not exactly what I want, but the eye was already vitrectomized by the former surgeon, so there was really no need to perform only a minimal anterior vitrectomy. I withdrew the IOL very careful, cut the two sutures because it was sutured in both haptics. One was broken and the other one was in place. And I just continue, I sutured the PC IOL with Prolene, and I just continue my corneal transplant. As conclusion, the middle segment surgery should be the job of the posterior segment of the VR surgeon, in my opinion, who can perform a pars-plana approach with complete vitrectomy and checking of the retina. And this is my current approach in most of the cases. On several selected cases, the anterior segment surgeon can solve and correctly perform a middle segment surgery as well. He or she also can do it when intraoperative surprises and complications appear, as you saw in my last two cases, which need to be fixed in the same surgery. My personal opinion is that the anterior segment surgeon must be trained in this specific situation so he or she can master the middle segment pathology and pars-plana approach. Thank you for your attention.